Hello, I'm Dr. Elliott. I'm a urologic surgeon who focuses on treating male and female urinary incontinence at Mayo Clinic in Rochester, Minnesota. As you know, this is a significant problem affecting millions of women in the United States. It's a problem that, due to childbirth, hysterectomy, age, all impacts upon the urethra and subsequent urinary leakage. There's a lot of confusion out there among patients and physicians as far as various different treatment options. At Mayo, we try to aggressively deal with first problem is evaluating the patient correctly. The most common errors and mistakes I see is that the incorrect diagnosis is made and then subsequently treatments are done that probably don't benefit the patient as well. So first and foremost in evaluation of the individual is the history. When did this start? How long has it been affecting you? The severity of the problem. What are you doing when you leak urine? Are you just sitting quietly or are you being active? An individual who leaks, like say sleeping at nighttime, has large leakage of urine, that is not due to stress incontinence. Usually that's due to overactive bladder, which again will have a completely separate treatment than for stress incontinence. Also, factors of previous GYN surgeries. Have they had a hysterectomy? Have they had previous anti-incontinence procedures? If they've had a previous anti-incontinence procedure, the treatment will be much more difficult than the first time case. Also, the impact upon the woman's quality of life. If she has light leakage, she's not bothered by this, she doesn't want anything done, then we don't do anything. That may sound simple, but pushing or encouraging a patient for treatment of the stress urinary incontinence usually does not work very well. An individual would not be pleased with the outcome if they feel like they've been forced into it. So it's just an openness of saying, here is an option available to you. Now, beyond the history, the next step would be the physical exam. Very, very important. The most accurate way to diagnose stress incontinence is a physical exam. It's not a urodynamics, which is $400, $500, $600 procedure that will usually not help us make the diagnosis nor recommend a various different treatment options. So on the physical exam, just like a standard pelvic exam, we see what the urethra looks like. Does the urethra move? Does it do something like this, or is it fixed or rigid? And the volume of urinary leakage. Is it a copious amount, forceful amount, or just really light drippage? Sometimes you have to have the patient stand up to get a better idea of the urinary leakage. But once we've made the diagnosis of stress incontinence and have ruled out other etiologies such as overactive bladder or overflowed bladder, which we evaluate with the post-void residual. It's very easy, just with a post-void machine or with a catheter. Then we're left with the treatment of stress incontinence. Think conservative measures such as Kegel exercises or biofeedback are warranted in some individuals. In the more severe individuals, it tends not to work very well. And then we're left only with minimally invasive procedures. First on that list is collagen or what's called bulking agents, which are designed to kind of tighten up the urethra. Good news about them is they're easy to do, minimal side effects. The downside is, number one, they're expensive, and number two, they are not a permanent fix. So I tend not to encourage that as a first-line treatment. If I'm going to do a surgery on an individual and it's minimally invasive, we have a lot of outpatient procedures we can do which have a good chance of success. So if we move from bulking agents, the next step would be considered a various different sling surgeries. There are many different sling surgeries out there. The most common one nowadays is called a Transobturator sling. Introduced about 7 or 8 years ago. Small incision in the vagina, about 2 centimeters or so, and a small incision outside of the vagina where the support is put under the urethra. Procedure takes about 15 minutes or so to do. Success is roughly 80% dry, 10% markedly improved, and 10% with only minimal improvement. And that's where it's very important when counseling the patient before surgery, saying, we do not have a guarantee of success. It's important to have a realistic expectations. We're trying to restore the support for the urethra that was lost with hysterectomy, childbirth, and age. Transobturator sling, very nice thing with it, has very minimal discomfort associated with it. There's some tightness in the pelvis and sometimes in the thighs. That goes away rapidly. And it's so the discomfort is so minimal that we actually have to warn patients, be careful, don't do lifting for 6 weeks. I actually have them circle on the calendar when 6 weeks is, so that they don't forget and go out and lift something. Now, the other option as far as a sling is called the suprapubic sling. There's, again, small incision in the vagina, roughly 2 centimeters, and then up top on the belly, right by the pubic bone, 2 little incisions, roughly about 5 millimeters, where you put a sling in. It forms kind of a U-shaped support for the urethra. This sling was originally introduced roughly in 1996 or so. It's a very good procedure. However, there are some increased risks associated with this because we have to pass some fairly long trocars or needles from the abdomen down to the incision in the vagina. So there's roughly a 10% risk of bladder injury, which is, as long as it's recognized, a minor situation. However, there's a potential risk for bleeding or, more importantly, bowel injury. And so at Mayo, we have a lot of individuals who had multiple previous operations, abdominal procedures. So I tend to shy away from the suprapubic sling in these individuals because we have increased risk for some major complications with that. However, ultimately, when it's said and done, the suprapubic sling is a very good procedure with a good chance of success, with the success being the same as the Transobturator sling. Next step is the traditional pubovaginal slings. There's cadaveric, using cadaveric tissue from a tissue bank, or autologous, using the patient's own tissue. These are rarely done nowadays because of these minimally invasive outpatient procedures. However, in institutions with where major referral centers or individuals who have had multiple previous operations, we have to deal a lot more with these autologous or cadaveric slings because we have a lot more complicated patients to deal with. Also, if you're doing reconstructive, like for urethrodivesticulum or any other type of significant reconstructive surgery for the urethra, we'll go more towards the autologous sling and cadaveric slings. The long-term data on cadaveric and autologous sling is very good. However, if the first-time individual who has first-time incontinence surgery, the data is encouraging that you can do an autologous sling, which is a large procedure, or an outpatient transobturator sling, which the success is going to be identical. Lastly is counseling of the patient. This is something that I stress significantly, that the patient has to have realistic expectations of what we're dealing with. We can usually make things tremendously better for an individual, but I stress I cannot, make it perfect. I cannot make it like it was prior to childbirth, age, and hysterectomy. Thank you for this opportunity of speaking to you about urinary incontinence. We're very proud of the work we've done at Mayo. It can be a complicated problem, especially in the revision surgeries. A lot of research is being done on this, and I feel that for both patient and physician, they need to see an individual who does large volumes of this to get the best chance of success, because the first time surgery is where we got the best chance of success.